What about continuing the IO therapy beyond progression? It's a question that comes up a lot for patients who come through my clinic where they're on a checkpoint inhibitor and they're slowly starting to progress, or they're progressing in 1 or 2 sites. Do you keep that IO agent going and add something? Do you stop the IO agent, switch to something different? How do you approach those patients?
In general, in my practice, I've been I think when somebody progresses on an agent, we have always said that that agent is no longer working. And I really haven't seen the data that has dissuaded me from that. The largest data set really was looking at atezolizumab in the OAK study. There they looked at patients that were continued beyond progression. I believe the response rate was about 7% in that analysis. That being said, there are all sorts of questions in my mind that come up with that. One, this is only a subset of patients that the practitioner felt were doing well enough to continue. So there may have been something that the practitioner said, even though they met the RECIST criteria for progression, that they, in fact, were not truly having a problem. The other thing is whether that's even a valid radiographic tool. I mean, RECIST, once you've progressed, you've progressed. And so how one can even define what a response is at that point is a little bit difficult. The other thing, again, when you do look at something like the docetaxel ramucirumab data, and this is taking a different study, I mean, the response rate there was 23%. So that's not saying that you would get 23% if you took those people that were doing well on atezolizumab and that you chose to continue, that you would get 23% in that group. But if you use that metric, that 7% is maybe not such a home run.
Mm-hmm. And one of the things I've seen in my clinic, and I don't know if you've seen it, but it's out there as well, that the patients who are on a checkpoint inhibitor and then got subsequent chemo seem to do a lot better on that subsequent chemo. I admittedly use a lower dose of docetaxel. I don't use the 75 milligrams per meter squared. I use 60. I find the 75 is hard to give. So there are options beyond progression. What do you do for the patient, Tom, who stopped and then they progressed 6 months or 8 months later? Or they were on chemo and then they progressed. Do you ever go back to an IO agent as opposed to they're on it and they're progressing, which Eddie said you stop?
So I've only had a few patients who've gone through maybe like the 2 years of pembrolizumab, and then that we observe them, and then there might be some growth. And generally, I've just started them as a fresh start. If it's a very short time after stopping the immunotherapy, I'm a little bit more skeptical and hesitant just to go back to the IO at this point. So I guess I'd summarize, I'd like to see like a 6 to 12 month treatment-free interval before going back.
And have you seen those, are they responding? Or are you seeing what we saw in Checkmate 153, where the patients who stopped at a year and then re-challenged, many of them did not re-respond?
I have to be honest, it's only a handful, and some of them I've done the carboplatin.
So it's hard to know. Hard to know what the response is from.
Yeah, I do this when there's the patient's really good performance status, asymptomatic, and it's only a handful of patients. I don't really know how to manage these situations, to be honest with you.
How about you?
Yeah, one, I must admit, I've been more aggressive about maintaining the PD-1 inhibitor probably than almost all my colleagues. I think the two inputs that go into that is that the study we were most involved in was the KEYNOTE-001 study, and that study treated forever, and we have people who are now on to year 7 of pembrolizumab. Do those people need pembrolizumab at this point? I have no idea. We were also involved in 153. And it does give me concerns about the restarting. The one additional thing that I would say is that there, in my mind, are 2 different types of progression that we see on immunotherapy. One is the old traditional progression we used to see with docetaxel, where all the disease was getting worse. But we definitely see a significant percentage of patients who are progressing, and clearly progressing by RECIST data, who are really progressing at a single site. And we actually, in those situations, have been fairly aggressive about treating with radiation or radiofrequency ablation, other locally ablative approaches. And many of those patients have continued to do well for long periods of time.
And then do you continue the pembrolizumab or whatever they were on, atezo, Nevo at that point?
So I've generally then continued on the patients who are on it, and interestingly, on patients who may have suffered a toxicity that led me to stop it, I've generally not resumed it, and oftentimes they do very well for long periods of time with no other problematic lesions.
I think it's really challenging because you're sort of trying to figure out, is it the disease or is it the treatment? And we're all in a very small data set, to work from individually.
Yeah, we have some of those patients. Our surgeons have also gone in and operated, and our surgeons describe, and it's also been out there in the literature, that when they operate on those patients, their lungs almost like radiation patients. Like they're very hard and they're fibrotic. But we also, depending on where they've progressed, looked at either plucking it out, but biopsying first to make sure that it's actually progression, because we've been fooled once or twice that it's granulomatous disease or other things before you immediately jump on the bandwagon of the next line of therapy.